My question goes to the medical community and to medical schools in this country and abroad. Are they gearing up to an aging population?
I think they're realizing it. I think, but are they really? No. I mean, I think it's fair to say we've been doing some work with geriatricians here in New York, and there, excuse me, there are a few medical specialties. Since I'm a pediatrician, I can say this: pediatrics, geriatrics, psychiatry. They're kind of at the low end of the totem pole on prestige in the medical world, and I think that the leadership of deans and directors has really got to get involved. I think everybody is preoccupied with the potential cost to the healthcare system. But the tack that seems to be being taken is how do we manage this development of palliative care, sort of how do we identify these high-cost cases, many of whom are older persons, and sort of manage it so the costs are not as high as they might be otherwise. But I think medical schools themselves are not really moving upstream very much in the prevention space. There's one difference there, the Association of Academic Health Centers, which is the national organization of sort of universities that have multiple schools of health professions, nursing, medicine, pharmacy, dentistry together, has directly taken on the social responsibility role of health systems and medical schools in dealing with broader determinants of health. So Steve Wortman has just taken it and run with it and has been really carrying it around from global meeting to global meeting. So I think they're dealing with the broader determinants, which then will lead us hopefully into the aging work and urban work.
Please, yes. Yeah, I must concur with the previous comment. Well, the data of bunch of information you gave will take a few years to digest everything. But I would like to make it even worse, if that is possible. Namely, all these projections in the future don't seem to take into account the canvas on which we project this. It's a world that's going to be warmer than what it is today. I'm a physical scientist, and I firmly believe that it's more than certain in our part of the spectrum that we are facing a future that's unlikely anything we have seen in the last 800,000 years or so. And so this is not an illusion, that is a fact. And there's more than anecdotal evidence that there are cases of malaria, there are cases of dengue fever, where they shouldn't have been, in principle. And that's because mosquitoes follow the isotherm, they don't follow anything else but what they and they can bring diseases that were never known in certain regions. So it's really a different world. I mean, if you project all this data into the future, there is a huge uncertainty because we don't. And I really hope that your community will give us a hand because we are fighting a war against skeptics and being very generous. And most, I should say, ignorance and economic interest, or the sum of the two together, which is really not very healthy for the future generation. Yeah. Unfortunately, we cannot sell anything but the truth, because that's what we have. And yet, I sincerely hope that the epidemiologists one day will come to fore and help us out. Otherwise, the people will not be convinced. I mean, it's frustrating to see that you have the data, satellite data, computer data, whatever, and then you go and people still don't believe you.
Yeah, I think I tried to kind of limit to a few areas, but one of the characteristics of cities that is very much on the agenda is climate change. And it's very fundamental to the urban researchers and urban investigators. And there's something called the heat island effect in cities, which really deals with exacerbating temperatures and causing, people saying they've never seen urban malaria or urban dengue. So you're absolutely right. It's just but it's not an area that's missing. It was just missing from my presentation. So the people doing urban health are totally, and also the risk of rising, because most great cities are on water edges, and so the risk of rising water levels to the survival of cities. So these are issues that people really do think about a lot.
There are estimated 600 million people living at the height of less than 1 meter from the seashore. So 600 million people can be at risk.
Yeah.
For having done absolutely nothing.
Yeah, I mean, we just, actually we've been taking a paper, a group of global group of medical academies, working with Sir Andrew Haynes at the UK Medical Academy, did some work on the mitigating health effects of climate change and the savings that might be available. And we've actually been trying to use that paper to influence the Durban conference and the Rio conference. And it looks like we're going to have a side session at Rio that's going to really focus on human health, because often human health is never discussed with the environment people. So, you know, it's an important issue.
Other questions, Mr. Pope?
Thank you. First of all, I add my compliments to your address, important remarks. I also was a principal deputy assistant secretary, but not in your agency. I was the principal deputy at the State Department for Counterterrorism. Oh. And I don't have a question, I just have a confirmation and a compliment. And the confirmation is something you were beginning to get to in the early part of your remarks, that issues such as health and NCDs and transnational diseases are actually national security issues,
yeah, they are,
as well as, of course, humanitarian issues. And so that's a compliment, a confirmation and a compliment to Dame Jillian, to her husband, to you, and to others who got it early on, and some others of us who got it perhaps a little later, was that dealing with these issues, particularly counterterrorism, is much broader than just trying to figure out how to break up Al-Qaeda, which is what, of course, we were by necessity focused on in the early days. But it's much broader than that. And these issues, and particularly health, have such a huge impact way beyond bioterrorism, which we knew about. But it's really critical. So my compliments to you. It's not really a question, but you all got it. And please keep making that point that these are national security issues.
I'm glad you said that. I think the Secretary Clinton sees that with the soft diplomacy idea. And there used to be a sort of, I don't know if it's still current, but the notion that that high infant mortality was a sign of a failed state or an incipient failed state, and that was a signal that many diplomats used when they were thinking about issues that they might be facing in their country. So I'm glad, I think it's even better for you to say it as a diplomat, so this is great.
A lot of that failed states.
Yeah.
And we still do.
Yes, please.
Thank you very much for your remarks. Couple points. The first is I was taken aback at the lost productivity number, the $7 trillion number you had in there.
Yeah.
Is there any data that you've seen that talks about the cost of trying to address that and shift the sort of resource allocation?
Yeah,
and then the second thing, the second question I have is you had also mentioned about lower income countries having a higher, is it aging?
Rates of aging, yeah.
But I was just reading in The Economist this past weekend that Africa, for instance, is on the precipice of possibly a demographic dividend based on the age profile. So how do we square those two kind of factoids?
Yeah, I think when we're talking about the aging issue, and we're talking about people over 65, and so one of the challenges is how do we get people to 65 healthy? That's that diagram, and part of the agenda with age-friendly cities or other sort of national aging agendas is to make sure that the folks that end up at 65 are healthy and aren't totally dependent and causing cost to the society. I think then the issue of more people living through the productive time of work and economic productivity is absolutely right. And that's what I was trying to allude to in terms of the successes of the sort of historical agenda of eliminating a lot of diseases and other activities that are allowing people to live longer. But when you live longer, you tend to get more chronic diseases, but not the workforce issues. I think our job is to keep them healthy, and that's why a lot of individuals are interested. David Bloom and Dr. Alwan, who were really the leads for the documents prepared for the high-level meeting, and WHO, they're on the WHO website, have identified a series of what they call best buys. So if you're a head of state in a country and looking at certain kinds of disease patterns, where would you put your money? Where would you invest first, and what the costs are? And those are all detailed there. So they've done a really terrific job of trying to guide the way on this.
Perhaps we have time for one more question. Yes.
I hate to raise the subject of politics, but it is that
I did.
it is the season, and I'm just curious what your organization would think about Obamacare in general, and also to address some of the topics that you raised this evening. And if your opinion is that it's not perfect, is there any sort of general sweeping comments you could make that might improve it, or tweak it, or make it better?
Well, not to go too far off message. I mean, I personally, having been through the Clinton failure, I went into the government in the Clinton administration because I thought it would be the only chance I had in my lifetime to see some kind of national health care reform, which is not easy because we don't have a tradition of national anything in the United States, so especially in health. I think any time this country is on the record as committed to providing universal financial coverage to its citizens for health care is a good thing. We're practically the only developed country that doesn't have some mechanism. I'm not arguing that it's public-private. I don't really care what it is. I mean, I do care, but I'm not an ideologue in that regard. I think the policy message of a commitment to universal coverage is something we've never had, and it has I mean, my Canadian colleagues actually believe that a commitment to this health and social safety net in the national health system in Canada actually has health effects, that people actually are influenced by the degree to which they have some confidence about being able to get health care or having social services. An interesting conversation. So that's my opening remark. And then I guess the other things I would say, I think a lot of the specifics are going to work out at the state level. I mean, we're following New York very closely, and obviously you have a state like New York that's quite committed to broad coverage and inclusion. You're going to have different results than you're going to have in other states. And the real question, I think, is how uniform is it going to be? Are we going to maintain this at least sort of baseline for everybody and then let states be creative? That's okay. But the other part of this that was quite radical to us is the emphasis, never before, on mandatory personal prevention. Has to be in the package. Things that are approved by the U.S. Preventive Services Task Force for age-appropriate personal prevention have to be provided by insurers without copay. Never happened before. Second thing is funding was provided for community-based interventions, which have shown very dramatic return on investment in tobacco, exercise, and diet, and a number of grant programs, very large ones, 600 million, 300 million are rolling out now to do that in communities. New York Health Department, City Health Department got about $6 million for its community transformation grants, which are sort of underway. And then also resources, a public health fund, and these structures I talked about a little bit. So it's really been the first time that a national health care reform document has spoken to the issue of prevention and public health. So we like that. It's the hidden part of the reform that nobody talks about, we try to talk about.
So